My name is Jennifer Drake Croft. I'm the Director of Child Wellbeing at the Tennessee Commission on Children and Youth, and I want to thank you all for joining us in our BSB webinar today. We have a wonderful presenter, Alison Peak. I'm going to read her bio really quickly before we let her start. So Alison Peak is a licensed clinical social worker, and she's also endorsed in infant mental health. She received her master's in social work from the University of Michigan with an emphasis in interpersonal practice with children and youth and infant mental health. Alison is the executive director of Allied Behavioral Health Solutions located in Nashville. ABHS works to improve access to behavioral health services toward a goal of better outcomes for all. Alison is the co-chair of the Association of Infant Mental Health in Tennessee Endorsement Committee and a member of AIM-High Tennessee's leadership cohort. In these positions, Alison is assisting in leading efforts to bring professionalization to Tennessee's workforce that serves young children and families. Alison also has 2 postgraduate degrees, Integrated Behavioral Health and Primary Care and Pediatric Integrated Health Services. Alison is passionate about working with children with histories of early trauma, families with adopted children, and youth in DCS custody. Alison also believes that these populations are often best served where they are most often present for assistance, their physician's office, and then in collaborating with primary care providers, it's possible to optimize services for children and families. So again, I just want to welcome Alison Peak. She will present for approximately 50 to 55 minutes, and then we will read aloud the questions that are posted in the chat box. Remember, if you kind of scroll on your screen, there are little icons below, and there's a little bubble icon that allows you to access your chat feature. So without further ado, Alison, take it away. Uh-oh, Alison, I think you're on mute. There we go.
Helpful when you can hear me. Good afternoon, everybody. I'm really glad to be with you all today and to be able to enjoy this time in this conversation. In this time of COVID, I must also say, welcome to my guest bedroom, where I'm sure many of you all find yourselves as well. So in this place of time, we are not all maybe as polished as we would have appeared 2 months ago, and yet it is still good to be together. For those of you who have never met me, there are a few things that are probably a good thing to know as we begin. One is that I have a bit of an accent, and I'm aware of that. And part of that just is who I am. Best I try, but I do know that that makes at points it difficult to understand me. Or so if there are questions, things that need to be clarified, don't hesitate to put it in the chat box, and Jen will reach out to me. I also really love when these presentations and times together can be conversational. So I'm really looking forward to hearing your all's questions and thoughts. We kind of process through this material in our time together. So I really wanted to take some time today to talk about like how ABHS specifically, but really kind of as a whole, the state is advancing infant and early childhood mental health through the Building Strong Brains innovation opportunities. So really in that, also wanted to give you guys a brief idea of who like ABHS is. So we are a locally owned organization dedicated to building relationships. We are a relationally focused organization with our staff, who we really function as a team, with our clients, and with our collaborative contacts. That piece of being able to build a better outcome for all, really near and dear to our heart. And so we really do believe that that's achieved through increased access to quality behavioral health services. Because of the way that we are set up and also the size of our organization, we are both large enough to get some things done and small enough to be flexible in our approach to services to really be able to create programming that is tailored to needs to fit gaps in communities and systems. And so within that, like we really leverage that all of our staff specialize in a variety of topics and treatment methods because we believe that that allows us the best opportunity to provide broad spectrum services to a wide range population. so that we know that we within our walls can serve just about everybody, but not everybody is a fit for every client. So that is also a big belief of ours. Currently, we have offices in Davidson, Sumner, and Jefferson counties in East Tennessee. So those are the three locations that we serve with pretty heavy concentration. Within our Sumner and Davidson County offices, we also reach into and serve families from Rutherford, Wilson, Williamson, Montgomery, Cheatham. That might be it. But really are looking at being kind of integral parts of our communities wherever our offices exist. So we primarily provide individual and family counseling. We do a fair amount of EAP collaboration around providing services for the greater workforce through a variety of providers and organizations. But
Hey, Allison, I'm so sorry to interrupt you. I think some folks are having trouble hearing you, so you might have to speak just a little louder.
my apologies for that. I'm very sorry. Is that better, Jen?
Much. I think just keeping your voice loud will be helpful.
That's the other caveat people should know. For some reason, this computer doesn't like it when I drop into a softer tone, and so sometimes it fights me on that. But so again, we provide EAP services to a broad range of employers and organizations. We also have an ABA team that functions primarily out of our Davidson County office, but within that, really do focus on working with children who have developmental delays, primarily autism spectrum disorder, who also have a history of trauma. So to be able to really combine those aspects so that there is kind of a trauma focused approach to that work and that really provides necessary support to those children and their families. We're going to talk about our early awareness, early response program today, but we are probably most proud of our multiple relationships. We collaborate closely with Davidson County's DCS program, but also with Upper and Mid Cumberland regions. We do a lot of EAP work with Metro Nashville Public Schools and also have a really neat program where we embed a clinician into at-risk elementary schools to provide services and support for teachers and staff and not students. We also work with Jefferson County Schools in East Tennessee to be able to provide mental health services in that county. There is not, outside of our services in the school, a mental health provider in that county currently. We do a lot of collaborative work with Tennessee Voices for Children, Vanderbilt's developmental medicine team, and also the psychiatric hospital. Really important as we begin a conversation about projects and building strong brains and thinking about infant mental health that we begin at the beginning. And there is a very large interconnected relationship between ACEs and infant mental health. And so the story begins that once upon a time there was a baby, but not really, because as the quote goes, there is no such thing as a baby. The quote by D.W. Winnicott, created in the 1950s, was this idea that there is no such thing as a baby. And the rest of the quote goes that there is only the mother-infant pair. Again, I wholeheartedly caveat that this is the 1950s, and so mother at that time was a very traditionally held role that we as professionals currently know that it really is the primary attachment caregiver and not so much the role of mom per se. However, babies exist in context of relationships. That is essential to the work of ACEs and to the work of infant mental health, that it all comes to this place of relationship. Without children, we are not parents, we are not aunts or uncles or cousins, we are individual people. I am not someone's aunt, I am just Allison. So in the context of that relationship, when there is a baby, we become something else, something additional. And in the context of that relationship, there is also security and survival for that baby. Because without the relationship, babies don't live. They don't really thrive emotionally, and physically, they are incredibly dependent on adults. And so, once upon a time, there was a baby, and also not really. Infant and early childhood mental health work really came to light in the 1970s through the work of a lady at the University of Michigan. Selma was a social worker at the College of Social Work who was working with Jean Piaget around developmental metrics and specifically around assisting families with children with visual impairments to meet developmental milestones. And in that, she began to realize that much of the work that she was doing and looking for really related to all families. Specifically, this came from the place of there was one time that Selma and her team were doing a control trial study. So, University of Michigan Hospital sent over a mom and a new infant for observation. This was the whole goal. Mom was 19 at the time, baby was about 4 months old. So mom was younger, but 19 in the 1970s was not terribly young. And so team brought the mom in. They're doing the observation through a two-way mirror, and this baby starts to cry. And cry. And cry. For 20 minutes. And mom never moves. Mom doesn't get up. Mom doesn't go to the baby. Mom doesn't blink. She never moves. Again, this is the 1970s. There are no 17 magazines. There is no smartphone. There's no Candy Crush. Mom just sits in a room with a screaming infant for 20 minutes and doesn't move. So Selma and her team really considered in that moment, what was it that made this baby's cries so hard to hear for this mom? And so through that, they really developed this idea of a deeply psychodynamic, relational, home-based model, which in the beginning, again, in the 1970s, was really called kitchen table therapy. Because the idea was that our greatest point of intervention for infants and young children was in the home, seeing the world and context in which parents and babies lived, and being able to support them from that place. Fast forward for a period of time, and there was a funding story. As many of us in any type of agency leadership are aware, there come times when we need money. So Selma went to the funder for the state-based Medicaid program in Michigan at that time. And she said, listen, we're doing this kitchen table therapy. It's really important. We're seeing great and amazing things. We need money. And the lady, whose name was Betty Tableman, said, that's great. But if I'm going to give you the money, it has to have the words mental health in the title. That is how the idea of infant mental health came to be the name, was because it allowed for a funding stream so that families could get access to resources. So this idea of infant mental health was incredibly grounded in this deeply relational, deeply psychodynamic work that really focused on intergenerational transmission of experiences as evidenced by what was referred to as ghosts in the nursery. There was this point in that mom sitting in this observation room for 20 minutes, hearing this baby cry without moving. That there were these unspeakable, unseen forces lurking in the shadows of this mom's internal capacity that made it difficult and often scary to engage in the emotional piece with that infant. So the term was coined that these were referred to as ghosts in the nursery. That from that psychodynamic perspective, it was often held that these forces were subconscious, often not of the awareness of the parent. And so that original model from the 1970s really serves as the foundation for current infant parent psychotherapy services, child parent psychotherapy, home visiting, both HFA, nurse family partnership, and parents as teachers, and other similar service delivery systems. That they really all find their roots shared in this place of Selma's work from the 1970s. Again, with that, given kind of the time frame in which the infant mental health movement began, and also that Selma was deeply a social worker, infant and early childhood mental health is well grounded in the old school social work belief of the incredible value of the clinical interview. It is probably both a strength and a shortcoming of the social work profession. Speaking as a social worker, that we believe strongly that the initial intake and that the relationship is key. We often don't spend as much time on metrics and outcomes. And so within that, this resulted in the majority of research being case reviews and kind of measures long-term of satisfaction. Some Some of that very much also had to do with the time frame in which the work was being done. In the 1970s, there weren't a lot of very like clinical data driven studies around outcomes of behavioral health. So the research grounding from the early years of infant mental health really is kind of limited to this place of case review and of self-report. But in the 1990s, most of us know the original ACE study was completed by Kaiser Permanente. And in many ways, there was for the first time clear evidence from a perspective other than behavioral and mental health that our early experiences and relationships have an incredible impact on how we function biologically, emotionally, and relationally. So, what does this mean for Tennessee? Approximately 10 years ago, Tennessee began grassroots movements around both infant mental health and ACEs. The two at the time really were similar in many ways. There were lots of people who were on those same kind of grassroots movements to be able to move things forward, for the state to be able to recognize the impact of ACEs on all Tennesseans, and also for the state to really recognize kind of within the provider workforce and also at a systems level that infant mental health really needed a greater focus and needed some place of development. And so through both of those movements and a lot of work by a lot of individuals, both the Association of Infant Mental Health in Tennessee and the Building Strong Brains innovation projects were developed. And both really began within about 6 or 8 months of each other. That there was this kind of simultaneous blossoming that so many years of work and research by numerous people came to this point of real shift within our state system to say, here the opportunity lies. What is the possibility that we can do with this? And so both of those entities, through their own visions, and they are slightly different. Again, like the Association of Infant Mental Health, the acronym is frequently referred to as AIM-HI Tennessee. So AIM-HI really does look at children birth to 72 months and their families, really looking at supporting the workforce that works directly with those young children. And Building Strong Brains really looks at the possibility of preventing, mitigating, and promoting awareness around adverse childhood experiences. So the work is related, and it is not exactly the same. But both have made considerable impacts on Tennessee's workforce and Tennessee's capacity to be able to provide services for those young children and families. So in 2017, ABHS opened with the goal of being able to provide services that resulted in better outcomes for all. So we focus a considerable amount of our resources on work with young children who have experienced trauma and infant and early childhood mental health work. So for us, it is core belief that ACEs are the evidence of the importance of this work, and that infant and early childhood mental health is for that mitigation and prevention. That we find that the two really are in an interconnected relationship, that they are dependent on each other to move us forward. So we have been fortunate enough to receive 2 separate Building Strong Brains innovation grants to be able to move infant and early childhood mental health workforce development forward across the state. So the first of those projects was what we called the Early Awareness, Early Response Grant. And so that was funded in fiscal year of 20. So that went from July of 19 to June of 20. Oh, yes, that's accurate. Sorry, I have to count, and sometimes that gets complicated. That is incorrect. It was fiscal year 19. We were funded from July of 18 through June of 19. And that was a 1-year non-renewable grant. The state at that time said, this was on the cusp of changing with the governors, the state said in that round of funding, like, we don't know what funding's going to look like long term. Get a limited pot of money, let's see what you can do with it. So we really were in that place focused on increasing capacity for diagnosis and evaluation of children 0 to 72 months. So after we completed that grant cycle, we went back and applied again, an expanded rate to be able to do some things for a longer period of time for what we call the DC05 Training Institute. So we are in the first year of that project, and we have been refunded for the coming year. And so that really did focus on increasing clinical workforce capacity for providing evidence-based models for children 0 to 72 months and their psychological parent. This term is really different and also really important. Through the Tennessee First 5 Training Institute, the piece that we are most focused on is being able to provide clinical capacity in areas where safe baby court teams exist, that there are clinical providers who can support the families in those safe baby court teams and who have a real understanding of the role of trauma in early childhood. And when we think about those kids in context of having experienced trauma, potentially living in places of chronic stress and trauma, and possibly being in the child welfare system, there's not always a biological parent present to hold them. Again, we go back to this quote of, there is no such thing as a baby, there is only a baby and. So we recognize emphatically through this project that there must always be an and. So sometimes that's not a bio parent. It may be a foster parent. It may be a preschool teacher. It could be a great aunt. And it is a foster parent. And these individuals step in and take on the role of that psychological parent, that person who is not biologically, but emotionally and cognitively available to that child to engage in the place of caregiving and to hold space for the work as we are able to process through trauma. So that's a really different verbiage, but is also really important in this place of doing good trauma work, that we always understand that it is a child and someone else. The Tennessee First 5 Training Institute also utilizes a 3-tier approach. We know that long-term change across systems really must invite reflection from everyone who's at the table. There needs to be people from all aspects in order to maintain change over time. One of my favorite stories is that we did a learning collaborative sometime back, and learning collaboratives by their virtue take time and effort and organization, quite a bit of money, and 2/3 of the way through, we had like 3 people move to Florida. It's great news for Florida, and left Tennessee in a place of, here we are. So we wanted to be able to invite reflection across systems so that regardless of the movement of providers, regardless of people's personal life decisions, that there was still a workforce intact and a system available to respond to the needs of children and families. So our first program through that early awareness, early response was to be able to focus on work around the DC 0 to 5. So that's the diagnostic classification manual for children 0 to 5, so 60 months. And so that is a diagnosis like nosology classification, just like the DSM, that trains professionals on a very different, it is its own unique, it is not an adaptation to the DSM, but trains professionals on the assessment and diagnosis of children birth to 5. So we did an initial 2-day training with 55 master's level or licensed clinicians, psychiatrists, with 1 physician, mental health nurse practitioners, psychologists, with a national 0 to 3 faculty. We provided everybody with a copy of the DC 0 to 5, and then we engaged them in a series of quarterly follow-up learning community calls with the national expert to be able to bolster learning and ensure that there was some level of efficacy and thought through the diagnosis process. We also did a webinar overview. It was a 90-minute webinar where we invited people to discuss like what they thought about the DC 0 to 5, questions that they had to learn about why it was important for children of this age to be diagnosed through a separate modality, to really have something that spoke to their development and their experience, and what that would mean for early childhood education and NICU nurses and home visitation. And then lastly, what we did through that project was a group of people from across the state, providers, managed care organization representatives. We had a developmental pediatrician and several other people to say, hey, like we have trained people, we have given them this knowledge, we have put it out in the system. how do we now make it reflective in our billing services? So we developed a crosswalk between the DC05 and the ICD-10 that agencies could then go back and build into their electronic health records so that they were able to effectively bill for services for children 0 to 5, and would be responsive of what they were seeing and representative of the work that they were doing. We rolled this out because we knew that diagnosis and assessment for young children was really important. Children birth to 60 months are a highly vulnerable population. This is one of the largest, most expansive times of cognitive and physical development across the lifespan. Developmentally, they are incapable at certain periods of time of any type of communication. And even at the most developed in this age range, their communication capacity is limited and often ineffective. And between birth and 5, we have minimal ability to advocate for ourselves. Children in this age range are statistically at a greater risk for both physical and verbal abuse. And long-term studies have found correlation between preschool expulsion and later incarceration and early intervention with long-term academic success. So we knew from the work of ACEs, we knew from the work of the preschool expulsion studies out of the Yale Child Studies Center that this was the time to be able to give voice to young children, support to families in an effort to be able to change their developmental trajectory. Kids birth to 60 months are also just different. Their symptomology is different, their needs are, the way that they express concerns is not clear cut. The DSM really is designed to be able to diagnose definitely children over 5, but primarily like older adolescents and adults. And so the diagnostications for depression for a 35-year-old just don't fit a 3-year-old. It doesn't look the same. It shouldn't look the same. They're in very different places in life. So again, this place of presentation, we recognize that providers were often not seeing the concerns about young children because it didn't fit what they had been taught to look for. We also really wanted to think through and give the gift of this nosology to the state because it is a diagnosis from a relational context. There's a piece within the DC05 that really looks at what the family's level of functioning is and what those caregivers bring to the relationship. So we wanted to underline that place that young children are born for relationships, and that relationship can both be a source of fear and a source of healing. We also knew in approaching that project that behavioral health, early childhood education, and medical providers are largely ill prepared for recognizing symptomology in infants and young children. Very few secondary, like graduate, post-grad programs across the nation teach the DC 0 to 5. I adjunct at several higher education institutes, and one class period I left my DC 0 to 5, and I thought surely somebody else on campus has one. I was incorrect about that. So it is not a thing that we often bring into classrooms, and those providers don't graduate with, and then they don't bring into a workforce. And so we knew that there was not that history. That lack of preparation then results in a workforce that's pretty anxious about providing diagnosis and services to children in this age range. Never talked about it. Nobody's told us what to look for. Seems like a really scary thing to embark on. It has not been long ago that the standard across the state was that mental health services were not provided to children under 6. That is changing some, but there are still organizations where that maintains to be the policy that they don't provide services to children under 6. Years ago, part of the justification for that was that there was belief that TennCare wouldn't pay for those services. That's one of the primary reasons that we chose to engage in this project, was that we felt like that wasn't accurate, that the real barrier in the system was that people were nervous about being able to provide a diagnosis, and diagnosis links to reimbursement. And so TennCare would not pay for a service without a diagnosis. People wouldn't give a diagnosis, so we couldn't get a service to link to payment. So we really thought that in closing that gap and providing people with education about how to make that diagnosis happen, that we could begin to close gaps in services. So, what did it do? A year, we put forth this effort. We had lots of setting into that project. And where did it take us? We did very rudimentary self-report data from all of our providers on this project. And we took free data before the actual 2-day training for the DC05. And at that time, what the providers who participated reported to us was that about 9% of total services that were reported were actually being paid for through TennCare. And that the vast majority of services that were being provided, 41% were being funded through grant funds. And when we took that data at the end of June of last year, right before the grant was over, we saw a dramatic shift in the way that people were identifying that they were receiving payment for services. We saw that shift in self-report data move to 48% of all services being provided were being paid for through TennCare, and that grant funding really did shrink to about 23%, which we really felt like was incredible data to be able to demonstrate that over 10 months, we had shifted provider behavior to that level. The other thing that we saw in the self-report data was that when we took the initial round before the 2-day training, we definitely saw that there was a higher number of children being seen closer to the age of 5. But if you'll look at the graph, even that, like on average, providers were seeing, and provider being like sometimes an entire agency, maybe was seeing 6 or 7 children. And so the graph at the end of the fourth quarter, there's still a pretty uneven distribution that older children are getting more services. But across the board, way more kids were getting services altogether. That even in that place, we were seeing a real report in increase of number of children being served rather than mostly grants and very few kids. It was mostly Medicaid and a lot more kids. And that was really so. After that, we were like, well, what next? And one of the big things that we heard in feedback around the early awareness, early response project was that providers and agencies were saying, like, this is great. Like, we have a pathway, we have an option. We got them in, we did an intake. What do we do? That we had removed a barrier, and now there was still this gap in knowledge of what's the treatment and intervention look like. And so that's where we came up with and developed the Tennessee First 5 Training Institute. And so it also has a real emphatic 3-prong approach. And the first being that we engaged a series of 7 agencies across the state in what we have called perspective planning, really helping them consider what infant and early childhood mental health services look like in their respective systems, what that means for their policies, their reimbursement rate, typical productivity metrics, the general layout of their offices, all kinds of nuances of what it means to build an infant and early childhood mental health system within a larger organization. So all of our current participants are listed there. And we asked each agencies to identify a number of providers that they would want to participate in an intensive 12-month training process. So we have 19 total clinicians represented from all of those agencies above that agreed to participate in. It is 7 different trainings plus weekly reflective supervision, and it equates to approximately 45 hours of training across a year. It is the equivalent of an additional master's degree. And these 19 individuals have stepped up and said, we will make this commitment to ourselves, to our organizations, to the young children and families who need our support. And so that process has been really amazing to watch, to work with these 19 individuals and to really see their development and what it means for then being able to provide services to young children and families in need. And the third piece to that was that we engaged in work around systems data assessment. I love the outcomes on those self-report measures that I just shared, and there are limitations to them. They are self-report measures. We can't verify them. We hope they're accurate. And so we knew in engaging in a larger, more intensive project that we really wanted to be able to look at the impact in a way that was verifiable. And so with that, we've with the managed care organizations and TennCare and being able to look at utilization data and identify areas where there really has been an increase in the number of referrals, the number of visits provided to children in 12-month brackets across birth to 72 months, and really looking at like how is this process developing across the state. It's one thing for us to be able to talk about it from a level of education or to be able to increase information within providers, but we want to make sure that the emphasis we are hoping for in the system is getting to children and families. So we're really excited about being able to pull that data together and to be able to use it to inform our work. So again, we really knew that there was once we closed the gap around billing and that then there was this gap around what do we do and how do we do services for infants and young children in a way that is relational. So often that gets referred to as dyadic, and also that it becomes trauma informed. And we also knew at that point that in an effort to make that shift, it would take considerable dedication, which we have been really a bit in awe, quite frankly, that those organizations and their staff have stepped up and said, this is important enough to us too, that we will make this happen. But what does this mean for the greater infant and early childhood mental health community? Those are all clinical shifts. Those are shifts within the behavioral health world. Those are shifts within how we hopefully deliver services in community mental health agencies, private practices, really focusing on that place of clinical trauma and trauma treatment. But historically, Tennessee has had infant and early childhood mental health services, a variety of other systems. Tennessee's home visiting, oh Lord, I lost my word. Tennessee's home visiting services have been robust and are high quality. The welcome baby packets that go out from the Department of Health are very public health, population health interventions around awareness of both ACEs and infant and early childhood mental health. There are infant toddler consultants through CCR&R. Tennessee Voices utilizes the pyramid model to be able to support awareness of social emotional needs in young children. All of these really are good promotion and prevention efforts that have existed in the state for a long time. But historically, we've been really limited on the intervention services. And concerns have been shared across multiple systems that there are families that have needs beyond what can be met through infant toddler consultation with CCR&R or beyond the capacity of a home visitor, and that those families then result in frustration within those programs. Families need more, that the program wants to give but isn't capable because that's not what they do. Families with frequent DCS contact or mental health concerns or profound trauma histories, even in benefiting from those other promotion and prevention opportunities, also need additional support. Again, home visiting was never designed for trauma work. CCR&R is not designed to be able to go out and do comorbid mental health treatment with parents who are experiencing mental health and substance abuse. And so building Tennessee's clinical early childhood mental health capacity really allows us to round out that continuum of services and offers the opportunity for vital services that already exist to begin to collaborate with clinical providers so that they really can meet the full needs of young children and families. What's next? What does that mean for us as a state? Prevention and promotion programs, you know the families that you serve best. You are in these families' homes. You have walked with them, sometimes from the birth of a baby until their third birthday. You hear their stories before most other providers. Being able to recognize that they may need a clinical intervention, that they may need something beyond what is currently being provided is really essential. So, in that, there's a real importance of knowing what options for services exist in your area. Through the Tennessee First Five Training Institute, we've been able to really expand that. That doesn't mean that there's a provider in every county. It does mean there's a provider in every region. So, yes, sometimes it looks like we get creative, that families drive a long way, that we, when possible, use telehealth. Um, and so, in that, like really being able to collaborate and reach out, but providers are there and they do exist in a way that 3 years ago the state didn't have. So, being able, if you've got questions or you're looking for somebody and you're not sure where a provider might be, feel free to reach out to Aim High Tennessee or to email me. My contact info is at the end of the presentation. We'll get there. But it's also really important in this place of for promotion and prevention programs in that relationship that you have with families, using that as a vehicle to be able to talk about what would it mean to go see a therapist? What would it mean to find a social worker who's got a background in infant and early childhood mental health? To sit with them when you make the phone calls and do the referral, to help them know what questions to ask. Because all parents, even in places that may not make sense to us, are working in ways to do what they feel is best for their baby. So in that place, we want to support that and say, like, how do we help you look for what we know is best for you and baby? So if you work in an area where there are limited options for infant and early childhood mental health services, reach out to your current referral contacts. Like, who do you usually refer to? And maybe you have a good collaborative relationship and they do really good work, but they don't have an infant mental health background. We are incredibly fortunate that Tennessee First Five Training Institute has been refunded for another year. So we've got ability to be able to provide that support and education to organizations. So encourage them to reach out, to get involved, to engage that training so that those good relationships that are already built can fully cover the experience of those families. One concern that we hear from agencies that are currently participating in Tennessee First Five Training Institute is that they're not sure about where to get referrals. Where are families with young children? And most of the time, they are with prevention and promotion programs. They are with pediatricians' offices. They are in library story times. So if you don't have a current referral contact, but you'd like to have one, then it's a place to reach out to agencies and check in about how to work with young children and families. Or again, to email me or Aim High Tennessee and to say, like, who's in my area? Like, who should I get to know? And in that place, there are some questions that you should know to ask. Ask them about whether or not they've ever heard of Tennessee First Five Training Institute and the DC05. If they're going to work with children under 5, they should know about the DC05. They should have participated in some level of supportive learning opportunity. Work with young children with trauma in that relational context is complex and is not a thing that you can like read a book and pick up and do. So you want to check in and say, like, what have you done to be able to provide this specialized service? Ask if they're receiving reflective supervision. This is a best practice standard. Like, it is part of how we provide services well and how we maintain a standard of high quality. That providers working with young children, especially when there's a history of trauma, are receiving that best practice standard. Ask about endorsement. They may not have it. They don't have to have it. But if they know about it, it means they're clued into our infant mental health community. It means they are aware of the things that are going on in the state, and that piece of development of workforce, of professionalization of our work together has an importance to them. Again, if you're a provider or you work with an agency, think about having them participate in the next round of training. We'll be sending out tons of emails in May and applications for agencies to participate. And so we would love to see new faces and new organizations and welcome back expansion for those that we've already had the privilege of being able to work with. And when you talk to families and organizations about ACEs, encourage them to think about the connection between ACEs and infant and early childhood mental health. Again, from our perspective, ACEs provide the research, and infant and early childhood mental health really do lend to the mitigation and the prevention of the impact of ACEs. And educate them on your role in both of those worlds. As a prevention provider, as a promotion provider, as I recently got the benefit of a conversation of a local police officer who really saw their role in being able to work with communities to de-escalate situations, to ensure that there was safety, as really being integral and vital to the success of young children and families. To really being able to communicate that core story of both ACEs and infant mental health in a way that lends to your piece of joining us in that work. Now, I must say that infant mental health is always in context, not just with babies and parents, but also in the way that we work. We never do anything by ourselves. So the work that ABHS has been able to do through these two Building Strong Brains innovation grants really would not be possible without the support of Aim High Tennessee and Blue Care, the Centers of Excellence, DCS, and the Tennessee Association of Mental Health Organizations. They've been integral providers and participants in being able to look at shifting our workforce to the extent possible. So we're really grateful for them. Again, that's my contact information. Any kind of questions that you all have, curiosities about referrals, curiosities about data or development of projects, please don't hesitate to reach out. We'd really love to be able to talk and to hear from you guys. So I am finished 3 minutes early. And
Awesome. Well, Alison, thank you again for that excellent presentation. And, we know that advancing the workforce in this area, advancing the awareness and competency in our state, and just expanding the system of delivery is really going to be one of the most important things that we can do to prevent ACEs and build strong brain architecture. So thank you for what you're doing. We have about 10 minutes for questions, and we've already had one come through. So as I said at the start, for the benefit of those who are joining by phone or who may watch this webinar later, it will be posted on our YouTube page. I'm going to read these aloud. The first question that we received is a question that says, is Alison aware of the National Council on Family Relations and Certified Family Life Educators? They are well-educated in multidisciplinary research and experienced child development and parenting. The CFLE would be a perfect candidate for training as well. Alison, you want to answer that?
Well, there's a curious answer to that. The short answer is I am not familiar with them. I would really love to hear more about that. One of the pieces that we have done a lot of work at, kind of at a national level, much more than a state level, just because of the need for it, is to begin to bring some of these groups together. Again, infant mental health really is a theoretical foundation, and there are lots of ways that that gets presented. Again, earlier I talked about like infant parent psychotherapy or child parent psychotherapy, but infant mental health also has its foundations in circle of security, trauma-based relational intervention, work in T. Berry Brazelton's like touch points model. And so there are so many kind of offshoots and groups that work with infants and young children that one of the big questions that we have been asking at the national level is who's not at the table and how do we begin to bridge those gaps? Because there are lots of people doing high quality work and research that aren't necessarily talking. So it's an awareness that we hold and that we're really kind of concentrating on, yeah, fixing over a period of time. But it's definitely a thing that we're still investigating to see who's not there. So yes, I would really love to learn more about that, um, and the opportunities that there might be to bridge those systems.
Wonderful. Our next question is, who in West Tennessee, who is in West Tennessee that early intervention providers could refer to?
Great question. So there, earlier we referenced the idea of a leadership cohort. And so when the endorsement system was brought to Tennessee, there was a selection of individuals for transparency purposes, all of whom had been trained outside of the state. Again, there are real gaps in our like systems of higher education and grad schools, post-grad schools around infant and early childhood mental health. But there were a number of people who were brought together to really think about developing the clinical workforce and moving it forward. And so when those individuals were selected, we were really intentional about making sure that there was representation from each of the grand regions. So for West Tennessee, the primary point of contact is Mindy Cronenberg, who's in Shelby County. Again, through Tennessee First 5 Training Institute, we are also working with Carey Counseling in their office out of Paris. So that's in Henry County. Positive Living Group in Jackson, so they cover Madison County, and then Behavior Services of the Mid-South, which is also in Shelby County. So there are providers in those 3 locations.
Okay. There's a question that I'll answer as far as a certificate mailed to you all for the time. We don't have that set up right now, simply because we haven't figured out exactly how to monitor engagement with these webinars. But it is something that we're thinking about, and we will figure out. And I think certainly a lot of accrediting bodies can take something like the proof of an email or something like that to say that you participated in this webinar. So there's another question that says, you referenced an abbreviation ABHS early in the presentation. What does that stand for, please? Allison, take it away.
ABHS is Allied Behavioral Health Solutions. It's the acronym that we have for our organization.
Okay, wonderful. The next question is, where do you get training to actually work with the children K through 2 in the school environment in steps of de-escalation training or teaching and resilience?
So infant and early childhood really does focus kind of 0 to 72 months. When we start talking about kids, I mean, K to 2, you're talking 5 to 8. And so they really, at that point, from a developmental capacity, are able to begin cognitive work. So you can do like narrative-based play therapy with a trauma-focused lens. You can do adaptations of TFCBT and EMDR at that age. A lot of traditionally held play therapy models are much more focused in that age range. The Centers of Excellence for Children in State's Custody do learning collaborative models quite frequently on TFCBT. They have one coming up on child family combined CBT, which would also work for that age range. And so those models really, they are adaptable to the entirety of kind of K through 8.
Okay. Next question is, prior to COVID-19, our kids couldn't receive telehealth under 10 care. How can we get services if this policy reverses?
It's an interesting question. This morning in a reflective supervision session that I had with a group of, they were home visiting supervisors, I used the quote that we find ourselves in the time between no longer and not yet. It's an odd space to be as a nation and as a state and as providers. In sitting in that space, I anticipate that not yet is going to look very different. One of the very frank, this is much an opinion and a soapbox. For people who know me, they know I have those from time to time. Telehealth allows us a lot of access into things that office-based services really don't. We are able to get to families who have limitations with transportation. We are able to get into rural communities in ways that driving 45 minutes, an hour and a half to a provider. Again, I gave those locations for providers in West Tennessee, but Lake County, like trying to get from Lake County to Shelby County or Madison County, is going to take forever. Um, so that's not realistic to ask of families when they are in places where they have had their own histories of trauma, they've got comorbid mental health concerns. So telehealth allows us the capacity to begin to really engage and work with those families. So I have real curiosities about what not yet will look like, especially in regards to how we are able to provide and be reimbursed for services through using telehealth through Medicaid.
Excellent, excellent reflection and answer. The next question is, do individuals apply to participate in the cohort or service provider organizations, and then the service provider organization select individual staff to participate? So reworded a little differently, is it by an individual basis, or do the organizations apply and then select who will participate?
The organizations apply and they select. We had organizations in this last cohort where individuals who participated took the opportunity to the organization and said, I feel like this would be beneficial for us and I would like to be able to participate. Organizations agreed to participate in kind of sponsoring that place of professional development for their staff and teams. But yes, the organization applies and then they identify who they want to participate in that application process.
Okay. Michelle Mosier has a comment for that slightly older age range that parent-child interact. It's interactive therapy, right? PCIT is available for ages 3 to 7. So that's another evidence-based model that can be used. Let me make sure I don't have any other questions, Allison. I think that that's all that we have. So we're ending just a few minutes early, but I want to thank you all so much for participating. And Allison, I especially want to thank you not only for leading this webinar today, but also for the amazing work you do in our state to improve the lives for children and families. You're a true leader.
Thank you guys for having me. It was my pleasure.
All right. Bye, everybody. Have a great day.